Just for everyone's awareness, this meeting is being recorded for record-keeping purposes. Everything said within the meeting and in the chat is part of the permanent recording, as well as what's in the video pictures as well, so just be aware of that. We appreciate everyone being here today. This is our third meeting looking at behavioral health alternative destinations. So my name is Gail Bradley. I'm the Medical Director for the Bureau of EMS and Trauma System here at ADHS.
Good morning. I'm Rachel Garcia, Bureau Chief for EMS and Trauma System.
Louise, Fire Chief, City of Goodyear.
Dan Jarrett, Assistant Chief, Daisy Mountain Fire Medical.
Trina Gallegos, Billing Manager, Daisy Mountain Fire.
Hi, Kristen Schurz. I'm an Organizational Health Coordinator with the City of Maricopa.
Sean Walker, Hospital Coordinator over Banner Strait.
Shelley Bissell, Bureau of EMS.
All right, thank you. It looks like we have a good number of people on the line. So we're going to go ahead and tee up, because this is a little bit of an offshoot, really focusing more on some of the connections with the health plans and the EMS agencies. I'm going to do just a brief kind of background of where we are. So if you can pull up the slides, please.
Okay.
We will go through that and then kind of go to the main portion. Hopefully we'll have some good discussion. All right, so just a little bit of background. I'm sure everyone in this room and online is aware that historically all behavioral health patients have been transported to the emergency department by EMS, which means while we understand certain patients go with a crisis response unit or law enforcement to a behavioral health facility, historically once EMS is on scene, those individuals were always transported to the emergency department. Once these patients get to the ED, they typically have pretty prolonged hold times. These can sometimes be days and weeks for certain patient populations, and this really strains the overall healthcare system. And while these individuals are being held in the ED, they unfortunately aren't getting the necessary psychiatric care and stabilization. So one of the things that we looked at coming out of COVID is what are some things that have kind of been brewing in the background. We know that behavioral health population has been increasing in the last several years, and we definitely have seen an increase in numbers during COVID, and that upward trend has continued. And so the Bureau decided to convene a stakeholder work group to look and see how can we address this patient population with the overarching goal to potentially divert some of these behavioral health patients from the emergency department when possible. So I'm going to go through some slides. Some of these we've kind of addressed already, but one of the things we wanted to do when we started this project was to identify the barriers. We recognized that there was a number of barriers which prevented EMS from taking patients to alternative destinations. We wanted to try to address what these were. The other piece was to bring together stakeholders, and really what we realized was this stakeholder group extends from the dispatch center, Solari and 988, EMS agencies, the hospitals, as well as behavioral health facilities. So we really wanted to figure out how can we bring everyone to the table. And then most importantly, and I think the goal of this meeting is to say, in order for this program to be successful, we really need the health plan's involvement. And so we are appreciative of everyone that's representing those organizations here on the meeting today. The other part of this is really looking at where can we increase the communication between these different segments. So looking at EMS and Solari, and we'll get into that a little bit later. And with the ultimate goal to be to transport the patient hopefully to the right destination the first time. And most importantly, we want to create a sustainable model that is also cost effective. So we're going to review some existing statutes and rules as it pertains to alternative destinations for behavioral health patients, along with associated billing requirements. We'll also very clearly want to keep stating this. We're not looking to replace existing infrastructure. We know that a lot of this work occurs very successfully with crisis response units, as well as law enforcement, and we're not looking to duplicate those efforts. We're rather looking to augment the system when EMS is involved. And the goal for this work group is really, again, to focus on behavioral health patients. That has been a question that's come to me, so I just wanted to highlight that piece. We know that there's lots of different medical conditions that can potentially be managed at alternative destinations. Those become a little bit more complicated because you start having transportation issues where someone with a medical condition, if they go to an urgent care, they may need transportation back. And so the goal for today is to really focus specifically with this project on behavioral health patients. We want to make sure that we're diverting appropriate patients with behavioral health crisis from the ED, understanding that there's going to be a percent of patients, whether it be from some type of ingestion or because they're too agitated or combative, that those individuals may need to go to an emergency department first for medical clearance. Also, certain age populations, age groups have higher risks and may need a little bit more screening. One of the things we wanted to do was to create a screening tool, and we will show you that later in the meeting as well, to help determine which patients can be safely transported to the ED. So that's one of the things that our statutory committees have taken on and helped approve for this work group as well. So the historical barriers, and I think the nice thing is we really were able to actually address this in the first meeting. So just for those of you that didn't participate in the first two meetings, the first barrier that we heard was, can EMS even transport directly to behavioral health facilities? And the answer is yes. And this is the associated statute and rule that allows for that to occur. The next question is, can EMS bill for transport to behavioral health facilities? And again, the answer is yes with the associated statutes. And then the third question, which is really why we're meeting today, is to try to look about reimbursement. So the feedback we got from EMS agencies was, if we've done these transports or if we try to do these transports, can we and will we get reimbursed? So at least for access and Medicaid patients, this is a revised statute that gives the actual rate that this would be reimbursed at for these transports. So the next piece we really wanted to do was look at working synergistically with the existing infrastructure. And I mentioned this previously. One of the things in kind of talking to the different areas, there's not a lot of knowledge amongst the general EMS community about 988, 211, and all the work that Solari does. And so we've really brought Solari to the table, and they've done some excellent presentations to this work group, as well as our EMS Council and other groups, to talk about the volume of patients and calls that they take care of on a regular basis. And so recognizing that we can actually help loop EMS and Solari in with 988 to address some of these patient populations. So we really wanted to highlight some of that work to raise the awareness of what they're able to do for this patient population. So with this collaboration, we really looked at some of the barriers. And one of the barriers that we recognize is that for some individuals, you may not even need any transport to a facility. But for an EMS perspective, they're typically not going to feel comfortable making that determination. So really engaging Solari at 988 and having that direct communication, it's possible that if they have that communication with Solari, that this individual may just have a phone conversation with Solari or 988 on the telephone and no one gets dispatched. Or it could be a situation where they say, you know what, we're going to send out a crisis response unit. The crisis response unit will meet with the individual to see if they need any transport. But there's other times where an EMS crew maybe could go back in service and they could utilize 988 as a bridge to help essentially manage that patient until a crisis unit could get there. So there's lots of different ways that relationship can increase. We really appreciate that all the work that Solari has done to kind of advertise what their services are. So one of the things that we had brought together, and certainly we had asked from this group, is this is the from Access. This is their list of crisis stabilization facilities across the state, and so this is the type of thing we want to make readily available. We understand fully that there's large portions of the state where they don't have the same availability of resources, but certainly within Maricopa County and Pima County, you see a pretty good volume of these facilities that are 24/7 crisis intake facilities, with one that are specifically pediatric as well. So that is really helpful to know which ones can take pediatric patients. Definitely we'd love to be able to get a list for EMS agencies. If health plans know these are facilities within your area, that's something the EMS agency can work with those facilities to figure out what would be their process for taking patients. The next piece was really being able to screen the behavioral patient population. This is something that our Medical Direction Commission really looked at and tried to improve, and I think did a great job with this, which is to try to screen patients. An individual agency's medical director can choose whether or not they want to adopt this in this format, but we wanted to have something that there's at least a statewide standard to really make sure that we're identifying patients who may have a more risky chief complaint, possible ingestion, or vital sign abnormalities. So this is the guideline that was put forward. There was just some subtle changes from the original version that was approved several years ago and that many agencies have used for some alternative destinations in the past. So this resource is also available and ready for implementation. And so next we're going to move to the discussion questions. Really, I would like to kind of go through these one at a time so we can leave these up. And the first is looking at, are there barriers to reimbursement? Are there barriers in the fee that limit payment? So I know that we have some representation from EMS agencies, and I believe the health plans. So I'm going to kick it off here and see if at first anyone has any questions about anything I've covered so far. And otherwise, I'd love to start addressing this and try to have this be a really collaborative discussion back and forth. All right, I do not see any questions online regarding the first part of it. So I will kind of start with, I will call up the EMS people because I know them. So what are some challenges? So I know from Surprise, I think Chastity, you said you were from Surprise. So I know you have probably, from an EMS agency perspective, done the most of this work from the 911 setting. So I don't know if you can maybe speak to some of the kind of success and challenges you've had with reimbursement and billing.
I'm brand new into this position as of October 31st. So I have Chief Rivera here. I don't know, do you have any feedback for them on that
Okay.
right now?
Yeah, so some of the, we know that we receive payment regularly from Medicaid. We don't really receive it from the other payers. But when we rolled this program out in 2015, we really wanted to make sure that if we had an option available for anyone, we wanted to make it available for everyone. It's firefighters, paramedics. We really aren't as familiar with insurances out in the field, nor do we concern ourselves with the type of insurance that people have. So we really just want to do what's best for the patient. And when we talk to the crews out in the field, that's really their biggest concern, is just doing what's best for the patient. But we're seeing that, Medicaid is a big supporter of this because of the support for the ET3 program and the Treat Prefer. On the Medicare side, it's specific to fee for service when it comes to ET3 alternate destination, but that's for agencies that were approved back in 2019. Overall, we probably see at our best about 43% reimbursement come in. So it seems that some of the peers may not, support it, or maybe they just don't pay for the type of service. So I see how that could be a challenge. If you're relying on the reimbursement to sustain your program. That's really where we're at. We don't really have much data beyond that, but those are the challenges that we see. Most people are very accepting of the service and very appreciative and support the program, would recommend the program, and would encourage others to use it as well. But yeah, the payment's just not at a high percentage of reimbursement.
Thank you, Jesus. So a couple questions in the chat that I see that tack on that. I will go to Joel's question first, which was historically the larger cities such as Phoenix indicated they were not reimbursed unless they took the patient to an ED. Has this changed? So this was one of those kind of urban myths that the Bureau really tried to address, which is looking at what was allowed in statute and rule. So this has been allowed. There was no new changes to the reimbursement being allowed for these type of transports. There was just some misunderstanding, I think, within both the Bureau as well as the EMS community about what was allowed. So that was our first two meetings looking at the barriers. So the short answer is yes, they can transport. Number one. Number two, they can bill for these. I think the third question, which Jesus is mentioning as well, is a little bit of the challenges in terms of getting the actual reimbursement. And so some of this gets into kind of the next step with some of the questions are there specific billing codes or diagnoses that should be used to help facilitate this? Does medical necessity need to be reimbursed? So those are some of the questions that came up. Does that answer your question, Joel?
Yeah, it does, and that's helpful, and it resonates to my time back and at the health plans. But now working at Connections, and overseeing the UPC, it's certainly still very much an anomaly to have fire or EMS bring folks directly, and it's still predominantly law enforcement.
Yes, and that's, I think what we're really trying to figure out is obviously if law enforcement or crisis units on scene is able to do this, that's great if they can take the patient. But there's going to be many times where EMS is there and there isn't another service available, and the patient does not need to go to the ED. And so we really want to facilitate that patient population getting to the emergency department. So trying to figure out kind of what can we do to help facilitate from the billing perspective. I don't know if any of the health plan representatives can maybe address some of the challenges that Chief Rivera mentioned in terms of some of their reimbursement.
So this is Johnny Getz with Arizona Complete Health and Care First. So I'd be happy to take a look at any errors that we've had in billing or any kind of claims that haven't been recouped on our end. But I'd probably want to see some, maybe if you'd like to email me some details, so that way we can pull it and identify where that might have occurred. I don't want to speak out of turn and say it's one thing without looking directly at the codes that were billed, so that way I can be ensure that I confirm. But again, our thought as a health plan on both ends, both through Care First and Arizona Complete Health, is that we are open to this, particularly if it involves members getting to the right level of care, like an observation unit, right?
Thank you. Anyone else from the health plans regarding any kind of barriers that they foresee on their end? I know that we do have some representatives from Access as well, who've been very active in the first couple of meetings. So next I see from Deb, there's state only Access reimburses for inpatient behavioral services. We're not reimbursing patients with this coverage. Will this change in the future? So I don't know. I think this was addressed to some degree. I think we have a couple individuals from Access. I know Dr. Salik had spoken on this briefly, but I don't want to misquote her on this. I don't know if someone from Access can address that question from Deb regarding the behavioral health service plan for Access.
We'll loop back with Dr. Salik related to what her response was and confirm the state only and get back to you. I don't want to give erroneous information.
Okay, thank you. So in this, just to clarify, this is a relatively small percent of the population, I believe, correct, that are on a small subset of an Access plan. Is that correct? This is not kind of your general Access patient population?
Yeah, typically state only refers to anyone that we consider non-titled, meaning those that do not meet the expectations and the requirements of that Medicaid funding. And we have limited funding for that based on our funding that we're allocated from the states. And we have very specific requirements to the non-title population. So we'll just provide that information, but you are correct. It does not meet the majority of the expectations related to Medicaid.
Okay, thank you. And then I see from Vince Martinez up in the northern region, the large commercial payers do not pay for alternative behavioral destination transport that bypass the ED. They create ambulance transport with emergency care, and alternative destinations do not meet that approval threshold. I know that this did come up with some previous conversations, and I believe that there was some feedback from some of the other health plans that they would feel that if this was an emergency that required 911 to be activated, that this would still count as an emergency. So I don't know if any of the health plans have any thoughts or input in terms of recommendations regarding like billing codes or diagnoses to help facilitate this type of reimbursement.
Just a question, I'm representing some of the health plans. When you say alternative destinations, are we talking straight to psych hospitals or?
Yes, so either a crisis stabilization unit or a psychiatric hospital.
So I think that maybe there's a little blurring of alternate destination. If the behavioral health facility is in fact licensed as a hospital and they're a Part A provider, then they are a hospital and under EMTALA and all the rules. So it's not really an alternate destination. It's still just, it's like a hospital, but it would be like a stroke center. It's just specific to that condition. So when we bill it, we could still do like scene to hospital modifiers. You wouldn't have to put like this was not a hospital on your claim. So they should pay it just like as if we took it to a more traditional hospital.
So quick question for you there. The subacute, or I should just speak for Connections. We're licensed as a subacute, so that that has multiple impacts on multiple levels, because we're not recognized as a level 1 facility. We're recognized as a level 1A. So I think there's some challenges with billing there as well.
Dr. Bradley, this is Vince.
Yes.
Alternative behavioral destination transports in Flagstaff in the rural area. We don't have any psychiatric hospitals up here, so we're talking exactly about what you just said. These are crisis stabilization units, right? The patient, according to our guidelines, our treatment guidelines, they are more than appropriate to go directly from the scene directly, to the crisis stabilization unit. So like the large commercials, like the Blues, Kaiser Permanente, United, they're the ones that they just, they don't approve these in any type of payment for these transports, because we are bypassing the ED, and they have this level of, well, doesn't meet that emergency threshold for an ambulance. They have, other means to get to that outpatient clinic. That's the rural perspective. Thank you.
Well, thank you for that, Vince. I don't know if there's any representations. I know we did address that in some regards, kind of at previous meetings, in terms of the feeling that those facilities are still taking someone who's having an acute emergency. And so looking to see what billing codes or diagnoses could help facilitate reimbursement for those situations, because there are definitely parts of the state that don't have an inpatient psychiatric hospital.
But it sounds like it's more the triggering diagnosis that this is an emergency situation. I think that's the big piece. And I think that's where the plans are saying, if they had if they could get there a different way other than ambulance, it may be more convenient, but I think that's probably where I think a lot of the disconnect is.
And I think, part of the challenge is right now, if they don't go to this facility, they're just going to go to the ED. So they're going to get transported to the emergency department and then ultimately get a secondary transfer and an ED bill. So kind of looking to see, can we just facilitate transport to a crisis stabilization center? Neil Thomas, I see you have your hand up.
Yes, thank you. Medicare looks at the destination licensing as part of their criteria for payment, and a lot of the health plans follow the Medicare guidelines, and some of these crisis outpatient units are licensed as outpatient units, not as hospitals, so it won't even get past their first edit. And if the health plans are following those same rules, that would be reason for denial.
Yeah, typically we pay off of Medicare, not all health plans, but the vast majority. And then we have a rate that's higher than Medicare because we're commercial. The Blues are, I think, the one exception to that. They have their own model. There may be some other ones, but that would be the challenge, is to do. And I'd have to look into if we've ever done custom codes or other things that are Arizona specific, but that's something I could look into.
And I would add along those lines into the bullet about medical necessity that they would be looking for medical necessity as well.
So I think that, some of the conversation in the last two meetings was looking at this. Certainly, Dr. Saligan Access has been very supportive of, they're happy to have these patients transported directly. From their perspective, it's a huge cost savings for them, just in terms of getting the patient directly to behavioral health facility versus an ED, then paying for all the ED charges and a secondary transfer. And so looking to see how we can hopefully expand that outside of just the Medicaid population, because definitely Medicaid felt like if they meet BLS criteria, that per statute, they're going to reimburse at the set rate. And if they meet ALS, if they have an ALS assessment done and end up getting an ALS transport, then they are statutorily required to pay and reimburse at that rate. So Medicaid definitely felt very comfortable that that would be something they would support, just because I think it's an ultimate cost savings for them.
May I ask for the representatives from the access pairs, if our destination modifier is P, which was what it would be for a non-facility destination, would that get paid? Because that's what it would be, the difference between transporting to a hospital versus an outpatient clinic. That destination modifier is P, so would that claim make it through for payment? Does anybody know?
I'm looking to see, I know we have, I'm just looking to see the names that I know are from specific.
Maybe the gentleman from Arizona Complete Care First representative.
Yeah, this is Johnny. I'm trying to look it up right now. Unfortunately, I don't have our claims team on the line, but I'm trying to ping them to see if I can get an answer for the group.
Okay. Since all the claims are sort of on an automated, if we send that claim with that P destination, it may just automatically kick back because their code edits won't allow it.
Got it. Can I put my contact information in the chat as well? So that way, if I can't get an answer right now from our UM team, maybe we can discuss further.
That would be great.
Fantastic. Thank you so much. I appreciate the group's patience.
And then while we're looking at that, I know there was a question above, I want to make sure I don't ignore, which was regarding the potentially agitated patient from Dr. Riddle. So this is something that, certainly it's going to be kind of how agitated those patients are. I think, there's a level of patients where if EMS is not needing to do any type of restraint or kind of, pharmacologic management of agitation, those patients that are maybe just kind of verbally agitated, those patients, they probably would feel comfortable. I think there may be a little bit of discomfort if someone is to the point that they can't transport them safely without any type of physical restraint or pharmacologic management. That patient population is probably the ones that would end up in the emergency department just due to the level of agitation. Does that answer your question?
It does, but just calling it out that we receive individuals that are very agitated regularly in the back of a police car in handcuffs. So somebody who is physically restrained because they were that agitated, I don't know that the crisis facilities would have a problem managing that at all because we manage that on a regular basis. Now, if EMS felt so compelled to provide psychopharmacologic management to the point that the individual was obtunded, I could understand then wanting to take them to the emergency department for medical clearance first. But otherwise, it probably truly isn't necessary and would be another wasted trip to the ED and a bunch of time spent that was not necessary.
Okay. Thank you for clarifying that. I appreciate that. I think I did see another, thank you for your contact information. And then I do see from Vince Martinez again, Access does pay for the majority of these alternative destination behavioral patients, which is great. So it sounds like that is being done. And so that is, one of the things trying to get kind of what are some of the urban myths out there in terms of where some of the billing challenges are. I think the ability to do this has definitely been addressed, but we really want to connect individuals who've had success with these transports and try to figure out, is there something that certain groups are doing differently versus others in terms of billing codes, diagnoses, to help facilitate that, understanding that a lot of medical billing is automatic, and then you can always go back and kind of try to get that claim paid. But are there other things that you can kind of do upfront potentially? So kind of the question about medical necessity, this is something that I think we chatted about with Dr. Stalick in the first two meetings, which is, looking at what does that actually mean? For a behavioral health patient, they need psychiatric stabilization. And so if that psychiatric stabilization needs to occur, that's obviously not going to occur in the emergency department. And if there's no other resource to take the patient, generally EMS is going to just take them to the ED. And so that was from her perspective why she felt comfortable with this being something that would be reimbursed at a Medicaid level. And then the question about prior authorization for 911 patients, this was another question that had come from EMS. From this perspective, again, from a Medicaid standpoint, their feeling was you don't need prior authorization for 911 call because it's you're accessing the 911 system, so that's not realistic. Completely separate situation where you have an interfacility transfer, that is different, but in terms of a 911 activation, there shouldn't be any need for a question about prior authorization. Chastity, I don't know if it's you or Chief Rivera, but I will open up to you guys. I see your hand raised.
Hey, Dr. Bradley, one thing I wanted to share there is a NENSIS field that we use that our billing company is able to recognize, and it is ET3 specific. Whether we offered ET3 service and the patient accepted, we offered it, they declined it, or we didn't offer it at all because it was unacceptable at the time. So it's just 3 buttons. it is available on Image Trend. It's something that we've been using that was created for the, created by CMS and is a NIMSIS question that we use. And that's usually what our billing company uses to identify that we use an alternate destination and to use the ET3 billing codes. So that might be something that's available or should be available in the EPCR system that people can use, you know, when they're working with their billing company to identify alternate destinations. But also wanted to share that when I look at the, and I sent you the email, Dr. Bradley, about the nationwide program, the Medicare fee-for-service. When I look at nationwide alternate destination, it looks like there's probably 50 or less transports per month. And when we look at reimbursements, there's probably less than 10 that are reimbursed per month. So I would say the reimbursement's really low. Overall, nationwide, the use is really low. I don't have an answer as to why. I think CMS is doing some surveys, trying to identify what some of the challenges are statewide. Hopefully they put out a report at the end of the Medicare program, which ends at the end of the year. I just wanted to share that information.
Thank you. And that was specific to the Medicare fee-for-service for ET3, correct?
Yes.
Yeah, and I think, the interesting thing is at the National Association of State EMS Officials Conference in earlier this year in San Diego, California, talked about some of their work that they've done at a statewide level. And they had done alternative destinations, and their overall plan looking over several years had really been looking at kind of all different areas. And they were initially thinking it was going to be for kind of avoiding readmissions, kind of more medical complexity type issues. And what they found was their greatest cost savings and their biggest volume of patients were patients that were taken to sobering centers and behavioral health facilities. And what they found was for their patient population, very large savings that they found in this report over a multi-year period, with the vast majority of the patients being in the behavioral health patient population. So it was very interesting data that they had put together in this report that I think was 7 or 8 years in the making of looking at data for this. So to the next question was really looking to see about types of facilities. So Access very kindly shared their list of crisis stabilization units, but we know that there's a large volume of behavioral health facilities that the health plans do pay for individuals to go to. So is there a way for an EMS agency to potentially find some of those? So that was one of the questions for the health plans is, do you have a list of these are the behavioral facilities that we will cover for patients going to? Certainly that's something that is a resource that EMS agencies can look and see on this list, which of these facilities are within our jurisdiction or reasonable distance from our jurisdiction to discuss as options for patients to go there. So some of those facilities, even though they aren't necessarily Medicaid facilities, do have 24/7 walk-in capability as well. And I know that quite a few of those facilities do take patients, both who come in by a private vehicle and law enforcement, but just trying to see how can we connect the two groups of kind of a known list of facilities for the private sector and kind of connect that with EMS. So that was one of the other questions for the health plans as well, as to see, is that resource something that you would be able to share with us that we could share with the EMS community?
So it's a little trickier question. Yes, we have directories that are easily accessible to, our members. The trick is there might be certain facilities, depending on what plan you have purchased, that may be in one Blue Cross plan or one United plan, but not in another United plan. So there's going to be some sloppiness, I guess, in technical term. But I think the first question is, are they at least in our broader network? I think we could probably figure out a way to do that. And they're highly regulated by federal law and state law. We have to update them regularly. But the trick is you may end up having an individual go to a facility because they're on an ACA plan that tends to have a narrower network of providers. What I don't know is how much crossover. Is this one of the areas where there's big differences in the size of the network, or that overlap may be very consistent across plans. So,
Just for people online, can you restate your name and
oh,
affiliation?
I'm Mark Osborne. I'm here with America's Health Insurance Plans.
I know we did have some discussions with the previous meetings. I believe Chief Rivera Surprise has had success taking directly to some private facilities that are not some of the Medicaid facilities as well, correct?
Yeah, so we use all the facilities in our area. Most of them do accept Medicare and Medicaid and commercial insurances. We use the REBA funded Recovery Innovations, Mine 24/7, and we've worked with them. But I think most of them do accept Medicare, Medicaid. Most of them Medicaid for sure. Some of them Medicare, depending on their clientele, age, and abilities.
Thank you.
And we would prefer everyone to go to in-network facilities because the cost differences are dramatic, on emergency situations. So, I mean, I think that's an issue that we'd be happy to try to figure out some ways to streamline that.
Thank you. And I think, one of the questions of kind of what we're looking at in terms of next step is how to kind of operationalize this. And so one of the things we wanted to do is, again, seeing the question that came up about, is this allowed? Really getting the messaging out there consistently to our EMS community, at our statewide meetings, our regional councils. You can absolutely do this work. You can bill for this work. I think a lot of that is kind of helping to get that messaging, as we've seen law enforcement really kind of adopt doing a lot of these transports, trying to get EMS to take this on as well. We would like to build out a section on our website, kind of really for this population, where we could keep a list of resources. So we would have kind of the information from these 3 meetings, the destination screening tool, other things like that. So if we had a list of facilities, the link to the Medicaid or Access list of crisis stabilization units. So any resources that this group would like to share with us, we can kind of link on there as well. And even if it's just a link directly to your facility or your company's website, or a list of resources, so that way as it updates, people aren't kind of going to an outdated list. Those are things we can definitely kind of put together to help packages to make it operationalized a little bit more easily.
There's also either quarterly or maybe twice a year that CRs have a meeting as a group as well. So I wonder if we could share that information with that group as well, because I mean they're going to be doing a majority of those transports too. So.
And for anyone who's maybe not aware, that would be the crisis response units from the fire department side of things.
Yes.
So the ones that are run by the fire department versus kind of ones that are run by Solari or the REBAs.
Dr. Bradley, can I just add, so this discussion about reimbursement and the plans and coverage, all that's very important. When we're talking about 911 patients, right, and our crews actually showing up in the living rooms, they're not going to have that discussion about what plan the patient may or may not have and what's the right facility based on that, right? So we certainly need to, if an agency is going to sort of embrace this program, you just need to be prepared that some of these transports just, maybe they're not covered. And, the crews are just going to do the good work in the field if it's the right thing to do. And so we need to continue to work on it on the back end, but these are going to be back end things that my billing managers can work on. Right.
Is it possible that these behavioral health hospitals, true hospital, Part A hospitals, can they operate as like a hospital does, where this is not in their network, but then they treat and triage, but then can refer them to a behavioral health facility that is in their network?
Usually what happens is under Impala, you stabilize the patient at the nearest, most appropriate, and then at some point in time, as fast as appropriate, then you transport them to an in-network facility.
And I think to tack onto that, and then I'll go to the 2 questions line. honestly, not every patient that goes to an initial intake or triage from a psychiatric perspective needs inpatient.
Right.
So many of these individuals may not end up needing any inpatient services. They may be able to go through like an intake, get, speak to someone, have some stabilization, get services, get referrals, and then they're discharged. So I think there's certainly the percent of patients that might need to get, full inpatient, but for some of these patients, it's really a matter of like that emergent stabilization of what's going on and that referral to kind of the next step. And so recognizing that it doesn't mean they're always going to have like a 3-day or a week-long inpatient stay. This patient may have a 6 to 8 hour stay, kind of just getting things stabilized or waiting their turn for an evaluation. So I think in order, it was Corey and then Johnny.
Thanks, Dr. Bradley. Yeah, so I have a couple of questions, I guess, and I'm trying to, obviously we're trying with Mesa, I work for Mesa Fire, and we are certainly trying to get more educated to what the options are in this arena. We have, I think we've, at least for most of our discussions within the fire service, have known for quite a while that transporting to a behavioral health or a crisis facility was allowed. The problem is that most of these ambulance operations need to have the ability to bill and reimburse. First and foremost, because it's required by the state of Arizona that we bill for our services. And then secondarily, most of these operations need to at least get cost recover, if not make money. So we're trying to figure out, we can bill for it, but do we get paid for it? That becomes a little bit problematic, is how are we going to get paid? Knowing that Access pays is certainly a huge benefit because a lot of these patients are Access patients. But to Chief Rivera's point, I'm still trying to figure out if privates will pay, because we've had some previous discussion, and Dr. Bradley, I've shared with you that we got feedback from one of our private companies, 5 private ambulance companies that are doing transports of behavioral health patients to behavioral health facilities. And what they relayed was they are getting paid. They are getting reimbursed, and at least there was belief that they were getting reimbursed from the privates. So to Trina's point, is that because, and it is, they're transporting to, I think, a facility that is attached to an honor hospital. Trina, to your point, would that be because of the type of behavioral facility it is? That I think they're using just regular TIN codes. I'm not really sure what their billing codes are, but they're transporting directly to a facility attached somehow to, I think, the honor system and getting paid. Would that be allowable today?
Yes, I think if, so long as they're using the H modifier as their destination, then the claim will be treated like it would be treated any other, as if you went to Honor Health Shea. It's all about that destination modifier, is the success of that payment.
So does that mean that today, at least certain facilities, like, to me, Gail, that would be a huge benefit, is if we knew, hey man, if you transport to here and here and here, that's like transporting to a hospital. Is that an option?
It sounds like that. Yes, it is. Because if, I'm not a billing expert, so I will absolutely kind of, from hearing what everyone's saying, it sounds like that billing code is, at least for potentially the commercial plans, maybe addresses some of the barriers because it does have that hospital code associated.
So I'll add, so we've turned this program on at my agency for 911 patients now. We've done some interfacility over the past 2 years, mostly to Quail Run. From my jurisdiction, that's going to be our closest behavioral facility, regardless of the type of facility. It just so happens to be licensed through the state as a psychiatric hospital. We're fortunate that way. And we have had success billing when we've gone to Quail Run. I've also met with them about the protocol and done all these things. We're comfortable in what they can accept there. And they, along the lines of the conversation we just had, they can, even if the patient becomes involuntary walking into the door there, they will direct that patient out of that facility to the right facility. From there, they said, you can just bring them here and we'll figure it out. So we've had success, and they are licensed as a hospital. I think that is a difference here when we're talking about billing.
Yeah, so we researched them, their facility, with their NPI and established that they were a Part A contracted destination hospital, and then we had that vetted by our attorney. So I suggest everyone maybe get a list of theirs and do the same, just so that you're not filing a false claim with that wrong modifier.
And then I see, Johnny, you had a really kind of tacking onto this in the chat, and you have your hand raised. If you can address, I think this is really helpful information you added in the chat there as well.
Yeah, just to touch on two things. So we're set up for ET3, and that modifier can be used for our members as well. And we're contracted in, so we should be good to go. And one thing that I just want to highlight, the benefit of using those 23-hour observation units versus finding a lift. I certainly understand there are some bigger locations in more rural communities, but the benefit of using those observation units is regardless of payer those individuals we serve, because it's a covered benefit by the REBA. So the REBA covers the initial 24 hours of an individual's stay at those observation units. So it means they're going to get that care. And to your point earlier, right, if that is 6 hours of care up to 24 hours of care for a connection to resources, a visit with the provider, medication bridging, et cetera, that should occur and is already a covered benefit for any individual in the state of Arizona, not just residents, not just folks with Medicaid or private pay. It's a covered service for anyone, so long as it's accessed through those observation units. So certainly a benefit there, just to highlight for this group.
Thank you. And then I believe, okay, that was your hand. And then Joel, is that for facility to facility transfer, or are we talking about AMBO directly to site facility? Was that in regards to Johnny's chat or something else?
No, that was in response to the gentleman before who
Okay.
was referring to the Quail Run transportation. Because I mean, we do facility transfers all day, every day, and those are required by AMBO, and those are typically reimbursed. So I was just curious if AMBOs are going directly to a psychiatric facility, and they're getting reimbursed.
So for us, we've just done the training and rolled out the protocol. I don't know that we've had experience with a 911 patient yet, but we're going to start just with Quail Run to say our medical director has vetted this facility and we're comfortable with their capabilities of the patient that they'll accept. And from our jurisdiction, the locality makes sense for us. From a billing standpoint, it makes sense for us. So that's kind of what we've trained our crews to say. This is going to be our behavioral health facility to start that's been vetted and approved. And we're just going to see how it goes.
And I think for those of you on the line that Chief Jarrett is from Daisy Mountain, so kind of like more the northern area and extending up pretty far north for some of those, so getting to some more rural locations as well. And so definitely looking to see how do you facilitate some of these transfers when you're not kind of in the central, close to all the different facilities that may be kind of here in more central Maricopa County or Pima County.
It was my understanding from a different work group that I'm on, that the Maricopa was direct to, it wasn't an interfacility, it was an emergency transport. So I think they have some experience with that.
Yes. And I think you're talking about Maricopa Ambulance.
Yeah.
Yes, and I think that's what Chief Hayes was referring to as well, was that those transports are occurring. And so again, we kind of know that there is like little pockets of this happening out there in the state. How do we really get that kind of brought together in a more global sense to help get everyone more comfortable that yes, you can do this and hopefully get reimbursed. And I think that leads to really the last question, which is, how do we potentially connect EMS agencies with the health plans if there's a specific point of contact to kind of work through some of these challenges? Because definitely, I think there is a lot of interest. We don't often get more than 20 people in our meetings. We're up to 63, plus those of us in the room today. So we're close to 70 people. This is hugely, definitely an area of interest for a lot of individuals. And I think for the EMS provider, I used this story at the very first meeting that we had of a patient whose family called 911 because they were suicidal. The patient was voluntary, was cooperative, had not ingested anything. They wanted to go directly to behavioral health facility. The crew didn't, that agency didn't think they could, so they called for a crisis unit. The crisis unit was going to be about 40 minutes just because of the time of day. And so they called the hospital to see, can we leave this patient with their family, who's very, they felt was reliable. And the physician said, no, you need to bring the patient against their will to the hospital. And so it was a huge dissatisfier for the patient who had been previously voluntary, his family, and really the EMS crew who felt like we're doing the wrong thing at this point. So I think from the people in the field who are going to be running these calls, I think they recognize that this is not where they necessarily want to take patients. As we see volumes right now in the emergency department are very high with just sick medical patients. Typically, a behavioral health patient is not someone that can go to the lobby. So these individuals either wait on the ambulance gurney for a bed in the ED, or they get put into a bed right away. But that means someone who's in the lobby or another ambulance patient with a medical complaint may wait much longer to get placed in a bed. So there is that trickle down effect. And I do think that the EMS provider in the field are really going to, if they feel like they can do this, I think for them, it's feeling like we're doing the right thing for the patient and the overall healthcare system. So I do feel just from what we hear that there will be good support for this.
Well, from a health plan perspective, it's super inefficient to send someone to an ED only to park them there and then have them re-referred. It's additional transport. I mean, that's not ideal care. So I mean, I think we're happy to be collaborative and try to work through some of these things. And let me figure out a way with the health plans to figure out who the specific person is in each health plan, and maybe create a working group of some kind or a listserv or something. I don't know. But I'd be happy to kind of facilitate that.
And that's, a point of contact list, we can kind of send it out strategically. We would not post that on our website. But we could certainly send out, to individuals who've been a part of this work group that are interested. We can kind of communicate some of that just to help facilitate some of this moving forward. I know within the central region, there's EMS Rock that has a billing subcommittee. That's kind of all the fire departments within Maricopa County that has a billing subcommittee. And so that might be a really good group to connect with that could really address it, at least in Maricopa County in a large region, rather than trying to share people's personal contact information globally. Any further questions or discussion on these at different points? I wanted to make sure we took some time to kind of go through these. So in summary, just I think make sure that we kind of hear what I think has occurred. It sounds like from a Medicaid perspective, this is something that gets reimbursed. It's not an issue, kind of whether it goes to crisis stabilization or a hospital billing code. From the commercial plans, it sounds like those patients, at least if you have a hospital billing code right now, will be reimbursed. Still a little bit of question regarding the crisis stabilization units or subacute facilities. And then also it sounds like that from Maricopa Ambulance perspective, that they may have already been doing these successfully to those facilities. And so maybe figuring out from their billing perspective, maybe we can try to connect with them and try and figure out what have they done to make this successful in regards to reimbursement. Teresa, I see your hand raised.
Yeah, thanks, Gail. I thank you for the discussion. It's been really helpful. And knowing that right now we are at, for pediatrics, a pretty high percent of utilization of pediatric beds, and December is historically large for pediatric behavioral health hospitalizations. I wonder if all of this applies and the resources are there as well for alternate destinations for the pediatric patients, and if you've all seen any increase or any challenges with pediatric behavioral health. Thanks.
Thank you, Teresa. So yes, there are from the crisis stabilization units, there are some pediatric specific ones that will take patients 24/7. So that is on the access list of crisis stabilization units. I think at least 3 pediatric facilities on there. There are also private facilities that will take different age groups, so kind of adolescent versus younger minors. And so that is the most challenging patient population often when they end up in the ED, because those patients, once they're in the ED, they're considered to be in a safe place, so they will have extended holds. So trying to figure out how to potentially get those patients to a behavioral health facility. The other component is also utilizing Solari real time from an EMS perspective, because they can do a lot of assistance with triaging as well on scene or sending a unit. So kind of recognizing we don't want to forget that resource for EMS is loop in Solari and 988 and see how they can help facilitate some maybe triaging of patients, because not every patient even needs to be transported. Sometimes the patients and their families just need some additional resources, and Solari has that expertise. So I think hopefully with those different things, it could address it. Because to your point, those patients will certainly hold a pediatric bed, a medical bed for a very long period of time once they're at the hospital.
Yeah, thanks, Gail. And last week I talked with Dr. Sean Elliott at TMC, infectious disease doctor, regarding RSV and the new white lung, even though it's not new. But he said even in their ED, 14 bed ED department had 20 stacked up waiting and triage. And I think having alternate destinations and not continuing to expand the EMS offload time. The emergency departments across the state, I don't have to tell this group that they are backed up like crazy, because people sometimes think that's the only place they can get care. And so having this discussion with some additional resources is extremely helpful. So thanks.
Okay. Thank you. And I'm going to go back to the chat, just a few things up. I see from Johnny Gasper, both himself and Amy Devons are happy to be point of contacts for AZCH and Care First. So I will make sure that those are information point of contacts. And yes, Amy did represent the team in the previous meeting with some contact information. So we can make sure that we share that out, because I know that they were willing to do that. And Amy, I see then your quote. Thank you. With directly with your telephone number. Thank you. And then Joel, your comment, connections is definitely seeing increasing youth behavioral health services at our Tucson facility, as echoed from what Teresa just said. And then Vince, to the point of in Flagstaff region, young pediatric patients under 12 are definitely transported to the ED. And then those patients are typically transported, it sounds like, outside of the Flagstaff area, just based on bed type and availability. And Frank, I know you had spoke at the last meeting as well. You have a Teams meeting every Wednesday with an upcoming one this week. And so definitely have to invite anyone within the central region that wants to participate. So thank you. We can definitely make sure that we connect those individuals with some of our other groups to help kind of facilitate some of these conversations moving forward. Next slide. So kind of next steps with this process. So we'll share a copy of the slide set from today. We'll distribute that to anyone who was attending at the meeting today. All of our public meetings are recorded and posted to the Bureau's website. So if you want to go back to the presentation, review any of the discussion items, or make sure you hear all the audio, those are publicly available as well. Shelley, can you remind me where those are found on the Bureau's website?
The EMS Council page.
Okay. So that is currently under our EMS Council, which is our statutory committee that this work group is technically falling under. Like I said, my goal is to really try to see if we can kind of reblend a portion of our website that's currently focused on treat and refer to include both alternative destinations and treat and refer. We can link these recordings to that page as well, just for ease of finding it. So that way you're not trying to click down kind of five layers to find it. But I think having a resource of where we can kind of put this all together. And then if you and your agency or entity has any additional resources that you want shared with this group, whether it just be your contact information, if you want to share it with Shelley, her email is there and we can help coordinate that. Thank you, Dr. Riddle, and Devin, I see your information there as well. So, any further discussion or comments moving forward? I think, definitely we want to make sure we get this information out as much as possible. Our next round of statutory meetings is the third Thursday in January. So we will give an update of this to EMS Council, which will be kind of a wrap-up meeting. We can also share a lot of this information. We've shared some of this work at our regional council meetings, but we continue to do that for our 4 regions over the next few months as well. Just making sure that people connect. I think sometimes at a region level, it's helpful to kind of connect certain regions with different areas in regards to the behavioral health system across the state. Are there any other questions or comments or feedback? Well, I appreciate everyone participating today. It sounds like we've had a lot of interest and success in this work, and we look forward to hopefully operationalizing this moving forward. So thank you.
Thanks.
Thank you.
Thank you.